So welcome everyone to the January edition of the AONA Trauma Journal Club, this one on rotational ankle fractures. I am Carolyn Tuga. I'm one of your moderators for tonight. And with me, I have Mary Kate Erdman from the University of Chicago, Damaya Hargett from Ventura County Medical Center, and Augustine Saez from University of California, Davis. So we have with us our guest lecturers for tonight. We've got Justin Haller from the University of Utah, Nilufar Degan from the University of Arizona, Tim White from the Edinburgh Clinic in the UK, and then David Sanders from the University of Western Ontario in London, Canada. So these are our faculty disclosures. Note that all relevant financial relationships have been mitigated and the AONA staff themselves don't have any financial relationships. And then, of course, the AONA does not endorse or promote any of particular product, service, or technique that we're describing tonight. And then, as per usual, Zoom etiquette is such that your microphones have been muted, your videos have been turned off. So if you would like to participate, which we hope you do, we encourage you to do so. Please use the Q&A box, and our moderators will monitor that throughout the session, and then we'll discuss at the end during a formal Q&A period. So as an overview, these monthly series are divided according to anatomic location or injury pattern. So tonight, rotational ankle injuries. And we'll interview authors from landmark orthopedic trauma articles to explore a little bit about why the study was done, its effect on practice, and any key takeaway points. The actual learning objectives for this session in particular kind of flow into the agenda. So we'll just hop to that slide. But basically, after these introductions, we'll start with my interview with Dr. Sanders on the operative versus non-operative treatment of unstable lateral malleolar fractures, an RCT. Early weight bearing and range of motion versus non-weight bearing and immobilization after open reduction and internal fixation of unstable ankle fractures will follow, which is Dr. Saez's interview with Dr. Degan. And then Dr. Erdman will be interviewing Dr. Haller with on the article, plafond malreduction and talar dome impaction accelerates arthrosis after SAD ankle fracture. And then finally, Dr. Hargett will be interviewing Dr. White on a prospective RCT of the fibular nail versus standard open reduction internal fixation for fixation of ankle fractures in elderly patients. Of note, it's about 1 a.m. in the UK right now, so Dr. White will not be with us. However, Dr. Hargett spent a good hour with him. So if you have any questions pertaining to this article or topic, please feel free to still ask them in the Q&A. And then after those 4 articles have been run through, we'll go and open up to the questions and the discussion period. And then we will be wrapping up by 9:15. So without further ado, we've got a lot of material to get through tonight. We'll just launch into that first article. Chris, are you able to launch that first video? Hi, everyone. I have with me Dr. David Sanders from the University of Western Ontario in Canada. He's the lead author on the paper Operative versus Non-Operative Treatment of Unstable Lateral Malleolar Fractures, a randomized multi-center trial. This was published in JOT in 2012, and of note was the recipient of the Bovell Award for Best Paper at the 2010 OTA annual meeting. So good afternoon, Dr. Sanders. Thank you for joining us.
Oh, thanks for the invitation. Good afternoon, Carolyn.
I was just wondering, this was a very impactful study. Can you give us a bit of the background for it?
Sure. I mean, it kind of all actually dates back to, what I experienced in my own training as an orthopedic resident, which actually predated the start of the whole wave towards doing stress examinations and that. And certainly when I was a resident, all these isolated lateral malleolar fractures would have been treated in a cast. And when I got into practice, after a couple of years, the idea of doing a stress test on an isolated lateral malleolar fracture came into play. And that was something I wasn't really sure if that was something important that I should add to my practice, something I should include, or honestly, something that we could probably do without. It became such a controversial topic without really good generalized agreement that I thought it warranted more study. And in particular for this one, because it's one of the simplest fractures that we deal with in orthopedic trauma. And you look at this little simple isolated lateral malleolar fracture and think, how can this be such a controversial topic? So I thought, man, this could really use a good answer.
Yeah. So this was a randomized controlled trial at multiple Canadian centers led by powered by the Canadian Orthopaedic Trauma Society.
Right.
And you guys looked at 1 year functional and clinical outcomes of the non-operative versus operative management of these stress positive, unstable distal fibular fractures. Is that correct?
That's exactly it. Yeah.
Okay. And specifically looking at non-union, malalignment, surgical site infections, removal of hardwares, and patient-reported outcomes.
Exactly. We were mostly interested in whether it was safe to do surgery or not to do surgery on these patients, or if we're possibly exposing people to a big risk of misalignment down the road.
Okay. And can you describe how you assessed ankle stability and determined these stress-positive ankles?
Yeah, it was basically an external rotation stress test in this study. So the patient would come to clinic. To qualify for the study, their static x-rays had to be basically normal with no evidence of any talar shift. And then in the clinic, not using anesthesia, no local or anything like that, we basically have them supine with their foot on a fluoro machine and perform a fairly gentle external rotation stress maneuver under live fluoro. And if the medial clear space opened, then they were considered stress positive.
Okay. And once they were determined to be stress positive, how did the operative versus non-operative groups get treated?
So we had because it's a multi-centered trial, what we've typically done with our Canadian trauma group is we have to come to a consensus on what would be necessarily an appropriate treatment for each group. It doesn't have to be exactly the same, but it has to be sort of within the standard of care for both the operative and non-operative group. And that's just how it has to work when you get a multi-centered trial going. Everyone has to be happy with the protocol, or else you just won't be able to get enough patients enrolled. So for this one in the operative group, you could treat them with either a posterior plate or a lateral plate with a lag screw, anti-glide or neutralization technique. But they did require stable fibular fixation and restoration of length. And then they could be mobilized afterwards with an air boot and protected weight bearing. Patients in the non-operative group, they were a little bit more controversial, and most of us preferred to treat these patients in a cast, non-weight bearing. But honestly, some centers don't have quite as good access to cast techs, and in those centers, the use of an air cast boot and even a bit of protected weight bearing would be the standard of care. So it's sort of defined by the center's usual practice for the study.
Okay. And what were the key findings?
Well, overall, there weren't any major statistically significant differences between the group. If you looked at the patient outcome scores, they're very similar between the two groups with really no detectable differences between the operative and non-operative side. However, there were a number of patients who developed misalignment in the non-operative group, and it was 8 patients out of about 40 in the non-operative group. So about a 20% risk of misalignment. And in the operative group, we had 1 patient who had a surgical site infection that required an operation, and 5 other patients who required hardware removal for irritation. So both groups had their share of complications, I would say, despite the fact that the outcomes were generally similar between the two.
Was any of that surprising in terms of the findings to you?
You know, a little bit. I was a little bit more concerned that these stress positive ankle fractures would develop misalignment. So to a certain extent, this study gave me much more confidence in treating these potentially unstable lateral malleolar fractures non-operatively. I was concerned that we'd have a real high rate of significant misalignment as an outcome of this study, and so were some of the co-authors. At the time, we were wondering if it was even safe to do this study. But as it turned out, the vast majority, or perhaps not the vast majority, but the majority of patients in the non-operative group actually did quite well.
And what do you make of the 20% malalignment in the non-operative group in terms of outcomes? Since, you know, you make mention of this a little bit in your discussion, but, you know, we looked at 1 year functional outcomes. Any thoughts on long-term functional outcomes or future study?
It would be really good. It would be fantastic if we could bring everyone back and re-examine them and repeat their radiographs and recheck everybody. on the good side of things, we picked up the most significant loss of malalignment was picked up early. We had one patient who had to be converted to the operative group. They basically did develop substantial instability and talar shift and got surgery on it and ended up doing fine. There were 5 patients, I believe, who had a misalignment detected late, who didn't end up getting surgery on it. And reassuringly, I've never actually had to operate on any of these patients late due to symptoms. As far as I can tell, they're all doing well symptomatically and functionally. So I guess the big question is this, 1 millimeter of lateral talar shift, is that actually a significant concern for people? Does it cause problems down the road like arthritis or not? And unfortunately, I think the jury on that is still a little bit out.
Okay. Did you get any feedback or interesting responses to this publication? Any hesitation to treat stress positive ankles non-operatively?
What was really awesome is we had 2 reviewers who had completely different viewpoints on whether they should be treated operatively or non-operatively. So, we submit the publication or the manuscript for publication, and you get the review back. And one of the reviewers was absolutely shocked that we would do this study and treat these patients non-operatively. And a second reviewer thought, what are you doing operating on any of these patients? That's crazy.
Yeah.
So it was actually kind of fun to go through that. So there was a little bit of controversy, which a little bit of tension between the different reviewers that made this really worthwhile to look at.
Yeah. Any modifications or improvements you would make to the study now, 10 years later?
Well, I think that there are some real potentials to kind of to think about this a little bit more scientifically. For one, like is a stress test really a binary outcome of yes, it's stable or no, it's unstable, or is it more of a graded degree of instability? And I think that the one patient, for example, who failed early actually had quite a positive stress test where it went from sort of 4 millimeters to like 7 or 8 millimeters of opening. And maybe there is a line, I don't know what it is, but maybe there's a line at which you have to say this is a really positive stress test and really needs to be worked on. So I think there's a little bit more subtlety maybe to the results of the stress test than certainly I appreciated when we did the study the first time around. Mm-hmm. The most obvious thing is that it would be great to have way more patients involved, and it would be great to have longer term follow-up. But then again, operative versus non-operative studies are difficult, and it took us 4 years to enroll enough patients for doing this relatively small study. So as much as I would like to have far more numbers, it's a tough challenge.
Right. And was there any subgroup analysis of the patients in each group? For instance, the smokers that you mentioned, or the differences in the non-operative treatment groups?
So we have the third author on the study, Brad Corbett. He works for Statistics Canada, and he was a real stickler for the whole stats side of things. So we hadn't defined subgroup analyses a priori prior to starting the study. So he was very resistant to doing anything like that. Okay. However, we did look at the numbers, and I think you're absolutely right that the patients that you'd think would be at risk of problems, like the smokers and the diabetics, those are the ones that run into problems with misalignment and with operative complications. So 100% it would be great to do a solid subgroup analysis on these patients.
Okay. And has your application of these findings changed over the last 10 years?
I think there's been some improvements to sort of how we do a stress test on patients. So the first thing is that number one, I'm really pretty happy to treat an older, lower demand patient non-operatively with any kind of positive stress test. At the time, we were doing the external rotation stress test, but now I'm probably satisfied if someone gives me a history of having walked on their ankle prior to getting an x-rayed or consistently prior to getting x-rayed. Or a gravity stress test is quite good. I'm not quite as much of a stickler of doing this formal external rotation stress test. Mm-hmm. And I still, I think that there's definitely a role for operative treatment in the younger patients with a positive stress test. So really those under 40 active types that really want a perfect outcome. I still apply this sort of algorithm fairly strictly that if they have a positive stress test, they will usually get an operation.
Anything else you'd want to add about this study or highlight or summarize that we didn't touch on?
No, I think that really the bottom line was that, you know, the non-operative treatment of a undisplaced ankle fracture is still a safe treatment, still quite a reasonable way to go for the vast majority of patients, and you can reassure them that they're probably going to do very well with that. And it's you know, it's reassuring for patients to hear that and to know that what we've been doing all these years has probably been pretty much the right thing for most people.
Okay, great. Well, thank you for taking the time to speak with us today.
All right. Hi, everyone. This is Augustine Saez. I'm an orthopedic trauma surgeon at UC Davis. And I'm talking with Dr. Degan at the Core Institute, University of Arizona in Phoenix, about her paper, Early Weight Bearing and Range of Motion versus Non-Weight Bearing and Immobilization After Open Reduction, Internal Fixation of Unstable Ankle Fractures, a randomized controlled trial published in JOT in 2016, and also noteworthy a 2013 Volvo Award paper at OTA. So thanks for being on, Dr. Degan, and taking the time to speak about this exciting research.
Thank you so much for having me. It's a pleasure to be here.
Awesome. I guess I'd like to start off with kind of where did the idea generate from, and how did you get all these surgeons and quite the list of people involved in a study like this?
Well, the idea started when I was a resident. We at University of Toronto, we have a 1 year of research where we have to conduct research that year. And I was kind of brainstorming with some of my supervisors about potential ideas. And Dr. Creeder, actually, who's one of the authors on the paper, came up with the idea because in general, he would allow his ankle fractures to weight bear immediately postoperatively. And some of the other surgeons at the same hospital would wait 2 weeks, some 4 weeks, some 6 weeks. So it was quite variable. And essentially, because of that variability, we thought it would be interesting to conduct a study to see, is there really a difference between early to delayed weight bearing and mobilization? And the reason we came up with the 2 weeks was really just picking a time spot that everyone would be happy and would participate in. Some of the surgeons weren't so comfortable allowing immediate weight bearing, so that's how we ended up with the 2 weeks compared to kind of the standard 6 week non-weight bearing, which was traditionally what was done at the time.
Nice. Obviously, impressive randomized controlled trial in orthopedic surgery. No surprises, an award winner. What went into being able to do a randomized controlled trial, getting people to participate and buy-in from surgeons who are on one side of the issue or the other?
Well, initially we started it at the one site at Sunnybrook Health Sciences, and we got buy-in from the other surgeons saying, hey, this is a potential study we're interested in. Would you be happy participating if we picked, let's say, 2 weeks and 6 weeks, if we had these, say, time spots? And most surgeons were happy participating in it. And then after we started it at that site, I moved on with my rotations and went to the other level 1 trauma center in Toronto, St. Michael's Hospital. And I basically started the study there as well to make it multi-center, to basically increase the enrollment and decrease the time needed to complete the study. It was pretty easy getting surgeon buy-in, especially trauma surgeons. In terms of patient buy-in, really, you just had to sit down and talk to the patients. And so I would routinely spend maybe 30 minutes or so talking to the patients, explaining the study, why we're doing it, the reasoning behind it, that both methods are done. We don't really know what's better. And really, the length of time you would spend talking to the patients would essentially correlate with them signing up for the study or not. So that's essentially how we did it.
Nice. That's awesome. So you're kind of the bridge, though, of bringing the study from one place to another. That's cool.
Yeah.
So, your study endpoints, a lot of them that we would expect on there: range of motion, kind of some patient-reported outcomes with the SF-36, functional scores of the ankle. The return to work one being the primary outcome. What was the impetus for that? It's a little bit different.
Yeah. So initially we were thinking of what would be, the whole idea of letting people walk earlier would be to potentially get them out to work sooner and, rehabilitate earlier. And that's why we started with the return to work as the primary outcome. And there was some literature at the time from other authors looking at return to work and potentially it being improved with early weight bearing, which is why we went with return to work. But in hindsight, I think one of the potentially the way we could have made it better is instead of capturing, it was a dichotomous outcome, as in have you returned to work, yes or no, at this point in time. So that made it more difficult to show a difference compared to if you were measuring it linearly in terms of how many days were you off of work. So we tried to go back and capture that as well, but it was made more difficult once the outcomes are captured.
Very interesting. Nice. So in terms of the results you got back, the early weight bearing group, better ankle range of motion, better SF36 scores, mental and physical, kind of some of the things maybe you would expect. Any results that you found that were surprising or maybe a little bit counterintuitive?
I think, as you said, most of it was pretty common sense. They'll be less stiffer and happier because they don't have a cast on. One thing that was surprising was the rate of hardware removal, or patients that had booked to have hardware removal in the future. So they were already booked for surgery to have hardware removal. And this is Canada. So just because you want to have your hardware removed now, it doesn't mean you have it removed now. It could be 6 months from now, but they were either removed or booked to have it removed. And that was a surprising finding that we found. We didn't think it would be such a difference, 10 in one group versus I think just 1 in the other group. And once we saw that, we started talking to other people at meetings and courses to see what their experience has been. And some of the other surgeons as well said, once you start mobilizing earlier, and we thought it was probably the range of motion as opposed to the weight bearing, that when you mobilize sooner, the soft tissues and tendons, especially perineals, get used to the implants being there, and there's less scarring in and potentially less irritation from the implants with the early mobilization as opposed to the delayed.
Nice. In terms of, context, so randomized controlled trial, 110 patients, pretty evenly distributed, 1-year follow-up. How did this start changing people's clinical practice, or what was kind of your feedback when you presented this and then following publication?
I mean, basically after this, I started, encouraging people and presenting and talking at meetings and various courses that, hey, it's safe to do early mobilization, early weight bearing, and early rehabilitation. So, I think it's a lot better now than it was at the time. That kind of knowledge translation, it took a while to get out there. And I find it interesting because in Europe, they're a lot more aggressive in terms of early mobilization, early weight bearing. In England and Netherlands and various parts of Europe, they're a lot more aggressive. It's really the US that's more conservative. So I basically try to teach and preach whenever I'm out at courses and meetings. And I think it has gotten better, especially when I see now people in the community, they are allowing earlier mobilization.
Nice. And then in terms of the early mobilization, were they wearing any cam boot or anything protective, or was it kind of up to the patient or anything?
It was early protected weight bearing. So they basically got it wasn't a cam walker, but it was essentially a boot that they got, and they were allowed to at 2 weeks start weight bearing as tolerated and take the boot off, move their ankle up and down, and do the range of motion. And once the 6-week mark hit, they were allowed to wean off of it. So it was really the same thing. And the 6-week delayed weight bearing group had essentially the same thing, just that at 6 weeks, that's when they got the boot and they were told to wean off of it. So it was protected weight bearing in a boot.
Excellent. Yeah. So is this your clinical practice now, or any further adaptations since this publication?
That's my clinical practice. So, and this excluded synesmosis injuries or posterior malleolus fracture that needed fixation. So a small posterior malleolus that you leave alone, I still let them weight bear at 2 weeks. If it's a large piece that I fix, then I may protect it. I don't think there's any evidence really for those fractures. We are actually doing another randomized control trial, essentially the same trial looking at synesmosis injuries now. So comparing 2 weeks to 6 weeks in patients who need synesmosis fixation. And we have, I think, about 20 or so patients randomized. We just started enrolling a few months ago. So I think hopefully that'll answer that question, because when I was in training with synesmosis injuries, some people would keep them non-weight bearing for 3 months, which I mean, when you think of it now, 3 months is a really long time. And I don't think I've kept anyone non-weight bearing 3 months for anything. So I think that's another area that there's a lot of variability and unknowns, and hopefully the new study will answer that question in that patient population.
Well, that's exciting. We'll definitely look forward to that. I guess anything you would want a reader to know that they maybe can't glean from the paper or the abstract? Any specific final thoughts?
I think an isolated ankle fractures can definitely weight bear early, especially elderly people. You want to let elderly people weight bear sooner, much like a hip fracture. You don't want to fix it and cast them forever. It should be noted that patients with neuropathy were excluded. So if you have a terrible diabetic who's neuropathic, they would not have been enrolled in this study. They would have been excluded. So those patients are different population. They need more fixation and more longer time for immobilization and protecting.
Is the thought they just can't self-regulate, the lack of pain response, or?
Exactly. I mean, they're neuropathic and they have no protective sensation, and they basically thrash it apart. So.
Gotcha. Great. Well, thanks for taking the time. Congratulations. A great paper, obviously award-winning, and has changed clinical practice, I think, for a lot of us. So appreciate you taking the time.
Well, thank you very much. And I want to say thanks to all my co-authors, Dr. Creeder, Jenkinson, McKeesha, Mitch Hall, and Stephen. They were all involved with the study. They were all my mentors at the time. So it definitely took a big team to complete the study. So thank you very much.
All right.
We're going to talk with Justin Holler out of University of Utah, and we're going to talk about his paper, Plafond Malreduction and Talar Dome Impaction Accelerates Arthrosis After Supination Adduction Ankle Fractures. This was published in 2021 in Foot and Ankle International. What prompted this study? Where were you at? What kind of discussions did you have with your co-authors, and what really was the genesis of this?
Yeah, thanks, Mary Kate, for having me and to talk about this paper. This was a collaborative effort between Harborview or University of Washington and the University of Utah. And in particularly myself and Mike Givens talked about supination adduction ankle fractures and quite a bit during fellowship. And one of the things we noticed was that there's just not a whole lot of evidence out there on the treatment for these injuries, just because they're so rare. I mean, they make up maybe 5 to 10% of ankle fractures. And so, and most of the studies were pretty small series. So we thought to really investigate this injury, we would need to combine, 10 years worth of data at 2 large centers in order to get enough patients with, to be able to say something about how they're best treated and how patients do with this injury.
Something I thought that was really interesting in your study was how you separated SAD type ankle fractures from pilons and the B type pilons, and curious what kind of discussion you had about how to do that and how to differentiate those two. And then now, a couple of years later, what do you tell residents or medical students how to separate those two? Because they're cousins in a sense.
Yeah, you're right. And honestly, a lot of times they're coded as pilons because they do have articular impaction a lot of the time. Like we found almost 3/4 of the time they do have some impaction. So it is common for them to be coded that way. And that's why we when we were doing the chart review, we had to review both kind of bimalleolar ankle fractures as well as pilon fractures, just to make sure we were capturing all of the appropriate injuries. We tried to stick to really true to the original definition, where you had like a tension failure on the lateral side, whether it's like an avulsion of the fibula or a true transverse fibular fracture, and then an associated vertical injury to the medial malleolus, and just try to note any associated articular injury or impaction with that. And that's kind of what we've continued to teach the residents to try to. There are definitely some variants out there. They'll look more like pilons. We try to exclude those just to be very strict with our indications.
Yeah, definitely. That you commented on the rate of impaction at about 3/4. Did that surprise you? Did you think it was gonna be higher, lower?
Yeah, it certainly surprises because what was out there before is I think around 40 to 60% of the time, which is pretty high still. But I think the difference for ours is that we had all CT scans to kind of confirm the impaction, which sometimes it can be kind of subtle. But we thought it was important to really quantify that. And I think for us going forward, at least I know at Harborview and here at Utah, all these injuries get CT scans going forward just to really be able to figure out whether they have impaction, and then to be able to address the impaction through anatomic reduction and make sure you maintain that. And so, but we were a little surprised with the amount of impaction that we saw in our results.
With these, they are typically high energy mechanisms from what you published. Do you see that these tend to have more issues with soft tissue swelling than the standard rotational ankle fracture? Does that affect your timing to OR? Are you X-fixing any of these? How do you manage the soft tissue resolution in this case?
Yeah, it's a great question. I don't know if we really looked at that in this study, but it would have been an interesting thing to look at. From personal experience, I haven't really had that much trouble with acute fixation of these. That being said, there still happens where they're too swollen for immediate internal fixation, but I think that's pretty rare. Whereas the flip side for me, for a pilon fracture, is pretty much every time they get external fixation and delayed overreduction internal fixation. So it's kind of, these injuries kind of fit somewhere in between a standard rotational ankle and a pilon fracture, and this is another kind of area where that remains true. It's like sometimes, but usually I can fix it acutely.
Yeah, it's certainly interesting, especially being like a partial articular injury. I think there's an element of stability. It's a little bit different than a true full bore pilon.
Yeah, absolutely.
I think an interesting element in your paper too is the talar dome lesion part of it. Is that something that you tend to look for more often now? Is that now that your awareness is kind of drawn to that a bit more? And how are you counseling some of these patients when you find that talar dome lesion? Because there's not a whole lot to do about it.
Yeah, that was one of the more surprising findings, I think, from the study, was that I think we reported a 30% incidence of talar dome, like kind of osteochondral or just fracture, particularly on the medial side. And it sort of makes sense mechanistically, but it was still surprising to see that frequent of an injury with these. And it certainly has us looking for it more often, and counseling patients that, they certainly have a higher risk of getting arthrosis with those injuries. And I think you're right. Currently, we there's nothing to really do for it, but it's certainly that's kind of maybe a further future area of study is what to do about these osteochondral lesions of the talus and these supination adduction or even pilon fractures, these high energy ankle injuries where we know that the talus plays an important role, and maybe we should be doing something different acutely for these injuries.
Yeah, for sure. And then what's your post-op protocol for these?
So usually they're in a splint for 2 weeks. For me, I usually keep them non-weight bearing for 8 to 10 weeks. And then again, that's a little bit dependent on if it's like multi-fragmentary marginal impaction that we're fixing versus if there's no impaction, that's probably more like 6 weeks. That's something that's still not quite figured out. I know we tried to look at that, but there's certainly some bias in our study where, worse injuries probably got longer delays to weight bearing. And but that would be something interesting to figure out. But currently I'm 8 to 10 weeks before I let them weight bear as tolerated, somewhere between an ankle fracture and a pilon for me.
Yeah, that's a variation on the theme, I suppose.
Yeah.
So if you had to redo this study, if you had to do it now or add anything to it, what would you change about it or augment in any way?
Well, I think one big thing to do would be to kind of expand the study a little bit to get more patients, because even though we had two big centers doing it, we still only had, I think, maybe 80 patients or something like that had more than a year follow-up. And so to really know how patients do, you need more than a year follow-up. So to have more than 80 patients, we would really need to recruit other centers. So that would be like the first step to really be able to answer some of these more interesting questions about, should we be treating these more like an ankle fracture, like a 6 weeks of non-weight bearing, fine. I know some of my partners do that versus, delayed weight bearing. We just didn't have the numbers, and it's tough to really to compare apples to apples in that situation. I think another thing that we tried to look at but just didn't have enough patients was fixation constructs. The majority of these got a medial sided buttress plate and plus minus lag screws. Some of them got just lag screws, and it would be interesting to know if those did worse. I suspect they would, but that'd be something else that we would look into a little bit more. Going forward, though, I think the most interesting thing is what you brought up with the talus and what to do about these osteochondral lesions. And they apparently occur more frequently than we know if they're happening in 30% of patients. So I think that's something for future study. I don't think we could have done anything different about that. But
any technical tips you have or pearls and pitfalls for addressing some of this impaction, like how to disimpact it, how to assess your reduction, and it can be pretty small fragments, and any tips you have as far as stabilizing those fragments?
Yeah, sure. I certainly think even though they could be really small pieces, trying to keep a portion of the subchondral bone attached to the piece when you're levering it down is really important. Using the talus to almost support your as you're disimpacting it, because I've had situations, not necessarily in this ankle fracture pattern, but in other scenarios where you over disimpact, and then it's really challenging to keep that piece from to be stable. Like it really wants to be unstable if you over disimpact and completely separate it from its surrounding bone. So I think using the talus to almost kind of cradle it down into its more natural position with a large piece of subchondral bone attached to it. And I think these pieces require independent fixation. So if they're real small, it's going to be 045 wires. If they're a little larger, think about a 2.0 or 2.4 plate with some lag screws through it to kind of raft the area and kind of contain the small piece. But for me, they always get independent fixation separate from the buttress plate along the medial malleolus.
So I'm Damaye Hargett. I'm an orthopedic trauma surgeon in Ventura, California at Ventura County Medical Center. And today I have Tim White joining us from the UK, and we're here to discuss his paper, a prospective randomized controlled trial of the fibular nail versus standard open reduction internal fixation for fixation of ankle fractures in the elderly, published in the British Editorial Society of Bone and Joint Surgery in 2016. Welcome, Tim.
Hi.
As I noticed in the paper that both groups were immediate weight bearing, but out of those 74 patients, 12 were smokers and 2 were diabetic. So I was just wondering, in practice, does your weight bearing protocol change based on patient factors, say diabetics and or smokers, or is the standard pretty much weight bearing immediately post-op for all parties?
Yeah, so the standard is weight bearing fully post-op, both for fibular nail and for actual ankle fixation with plates and screws. Those that don't come into those criteria would be diabetics with peripheral neuropathy, any other individual with peripheral neuropathy for another reason. We're also quite cautious with patients with psychiatric problems. And the final group, I guess, would be patients with large type 4 posterior malleolar fractures. But really, all other patients are weight bearing straight away, which is particularly useful in this age group of elderly patients with ankle fractures in whom restricted weight bearing is such a problem.
Yeah, it's very difficult for a lot to even be compliant with that. We can tell them to do it, but a lot of them actually don't comply.
No, absolutely. The diabetic ones are a different problem, really, aren't they? I think those that have a dense peripheral neuropathy, thankfully, are also those that have a relatively low level of mobility anyway. And we've tended to move to hindfoot nails for those patients.
Yeah, that seems to be the trend here as well. So in the study, you noted if we take into consideration the cost between the two groups, that there was a small financial advantage with the nail, despite the increased initial cost due to the amount of complications related to hardware failure. But you also noted that the average time in the OR was less. Do you have any roundabout numbers that you could provide? They weren't specific in the paper, but I'm assuming with the decreased OR time, that would also kind of add to the bottom line as far as overall decrease cost. What would you say the average time difference is between the two in your hands?
Yeah, so I guess in my hands, having done one or two of them, I rarely take more than 20 minutes to do a fibular nail. The setup is a little faster, I guess, because we don't use a tourniquet. Using a tourniquet less and less for ankle fractures in general, but certainly for a fibular nail, direct visualization of the fragments is not an issue. It's a fluoroscopic reduction, so no tourniquet required. In this age group, if the medial malleolus lines up well after lateral malleolus fixation, we tend not to fix that. And published and presented a paper at the OTA on that just a couple of months ago. And so it really makes for a very quick operation. So I would say, it could be easily half the time required for an open reduction internal fixation.
Wow, half. Yeah, so that's a significant cost savings. How do you assess, or how did you guys determine that 3 millimeters was the acceptable cutoff point in this paper?
Yeah, this is the big mental jump, I think, that everyone has to go through to go from fixation with plates and screws to a nail. And so I think there are a couple of key things. The first thing is, of course, that our experience of treating SER2 fractures that don't require surgery is that when you look carefully at the fracture, there is often a degree of displacement, and particularly on the lateral, the part that normally sits out most is that posterior spike. And so my start point there was, if I would accept that position on an X-ray of an SER2 fracture at follow-up, then it was suitable for the X-ray at the end of the procedure. So that's where that 3 millimeters came from. In actual fact, it's rare for that to sit off much more. They usually do line up very nicely. The other thing to bear in mind is the fact that in an SER2 fracture, that step off that we see is not due to the distal fragment having rotated away from the talus. It's due to the proximal fragment having rotated internally under the action of the anterior and lateral compartment muscles. And there are a couple of nice papers from Michelson and Harper where they scanned the whole leg in patients with an SER2 fracture, looking to see which fragment it was that was displaced, and it's the proximal fragment. So when we look at those, there's no advantage in struggling to make the proximal fragment line up with the distal fragment. And I think that's the big mental jump that we have to go through for acceptability for the nail. So we're taught as residents, and I guess our predecessors since the AO group started fixing them regularly in the 1960s, that you've got to get the cortex perfect. Otherwise, the ankle's not perfect. And the reason, of course, is that in the early stages, getting the cortex perfect was the only way to get the joint perfect, because they didn't use fluoroscopy. So it was a requirement in order to get the ankle joint reduced. Now that we have fluoroscopy, we can make that mortise perfect without having to be concerned about what that proximal fragment is doing. And so I think that's the big mental jump in acceptability that people need to make.
The whole goal is to preserve the soft tissue. So some would argue if you're going to have to do an open reduction of the fracture, then why not just proceed with traditional open reduction internal fixation? What would be your response in that particular situation?
Yeah, I can see that argument. I think the counter would be that it's actually rarely required once you've got the hang of the device. The other thing I would say is even if you do require to open it, then actually the length of the incision to open the fracture and put a clamp on it is quite a lot less than you would usually require to extend the plate above and below the fracture with 3 screws on each side. And then once the device is in, of course, there's no subcutaneous metalwork. So you just have to close the skin over the bone rather than over the bone plus hardware. So I think even with that, there's a substantial advantage.
What would you say, based on this paper and your experience, what would you say to the trauma surgeon or the foot and ankle surgeon who has read papers on this, but yet hasn't adopted this in their practice?
I would say that the technique aims to give you an anatomical reduction of the mortise and enough stability for the patient to weight bear with minimal risk of complications. And that really is, after all, exactly what we're after for our patients. And that there is now an extensive literature from many centers, including several really good meta-analyses, that confirm that that is the case, and it is achieved across the piece in several centers, not just in enthusiasts like us in Edinburgh, but actually all across the world. That level of success can be achieved predictably with these devices.
Now, so in your practice, what's your current indications? Like, are you predominantly doing fibular nailing now, or is there still some role for, there's always some role, but what are your indications for who you're nailing and who's getting your traditional plate and screw construct?
Yeah, so I think personally, I would like to use a fibular nail for virtually all of our fractures, but the side effect profile with relation to soft tissues is not such a significant problem for patients under the age of 60, 65 with good tissues. So those patients still get standard AO anatomic reduction and lag screw fixation with a plate. So the fibular nail in our hands at the moment is for the over 65s, those with compromised soft tissues of any age, diabetics. And the other group, the other 2 groups, I guess, are those with pronation abduction fractures, where there's a long length of comminuted bone that you wouldn't be able to reduce and compress anyway, that you're going to be looking to bridge, even if you plate, are ideal. And the final group are pilon fractures. And to be able to give some stability to the lateral column without adding another long incision to the ankle in that situation has a great deal of advantage as well. So we use 1 incision or sometimes 2 for the tibia, but avoid making a 3rd incision for the fibula.
You published some biomechanical studies looking at nail construct versus plating, and demonstrated that there was higher load to failure with fibula nails. Would you like to help elaborate on that a little bit, or provide us some more information on biomechanical benefits of nail over a plate?
Yeah, can I share my screen?
Yes, please.
And just show you. So we did a study on the biomechanical strength of the nail, and we had paired cadaveric ankles. Can you see that okay?
Yes, I can.
That appeared. Okay, great. So these are paired cadaveric ankles, and we took one and we did a standard fixation of an SER4 fracture with a plate and screws and a lag screw, and one with a fibular nail. And you're quite right, the peak torque to failure, so the strength of the construct, is higher for the fibular nail. But what was also interested was a mechanism of failure. So if I just show you the plate and screws, first of all. Okay, so can you see that? Do you see that that's,
Yes. Mm-hmm.
it fails in more or less the manner that you might expect clinically. The fracture eventually distorts to the point where the screws pull out and the plate becomes displaced. Okay, and if you compare that with the fibular nail, ultimately, if you twist that hard enough, it also fails. But look what happens there. The fibular fracture itself has remained aligned. And what's happened there is that the distal fibula has pulled off the talus and the calcaneus, which is not a mechanism of failure that we see clinically. So that gives you an indication of just how tough and powerful that construct is when compared to preventing pullout of individual screws in osteoporotic bone. And we repeated that study with locked plates, and exactly the same findings are seen.
Yeah, so that's further adding to the pros of using a nail over your standard fixation, especially in the elderly.
Okay, so those are our 4 interviews that we were going to go through. We can open up to some questions now. I saw a couple in the Q&A box. If Dr. Saez or Erdman, if you guys want to.
Yeah, for sure. So the first question was for Dr. Dagon. In your study, what was the construct you were using for fixing the fibula? There's a question, was it anatomic locking plates or a different type of construct? And then I think, for the whole panel, is there any way that depends, the way you fix an ankle, is there a way to load people up or, put in more implants that you can then more reliably let these people weight bear sooner with less concern? Or is it mostly based on fracture pattern? So maybe Dr. Dagon, you want to talk about the study first though?
Yes, that's a great question. So the fixation was plate and screws with 1/3 tubular plates, essentially. We didn't have anatomic plates at the time. So 1/3 tubular plates.
Or is that what you're still using, or have you switched to anatomic locking maybe for biomechanical strength or let people walk sooner?
To be honest, now I'm breaking the budget and using the pre-contoured fibular plates that we didn't have in Canada at the time. I just find they're lower profile and potentially decreased risk of hardware removal, but I have no scientific evidence for that. If it's higher up, so the distal fractures, I use the pre-contour just because I can get a better cluster distally. It makes me feel better. But if it's higher up, like Weber sees, then I would just use a 1/3 tubular plate. 1/3 tubular plate.
All right. And then any of the other authors have any thoughts on, whether your choice of implant or amount of fixation changes whether you weight bear or not? Or is everyone just everything gets weight bear is tolerated?
Yeah, I guess I can jump in. I almost always still just use the simplest 1/3 tubular construct, and it's just amazing. Just like Nilüfer said, you really don't have to go to a locking plate to reduce the risk of failure. It's for other reasons like hardware prominence and that kind of thing. For the average healthy younger person that you're operating on, for the smokers, diabetics, and people you're a little less sure about, then probably a little more extensive hardware is going to be helpful. But for the average person, the cheap plate works great, and you can allow weight bearing with a pretty low risk profile.
Mm.
Can I ask a question from Dr. White?
Yes, he's not on the line, but we might try to field it.
Okay. I guess it'd be difficult to answer if he's not online. He mentioned the hindfoot nailing, and I was wondering who he's doing that for instead of the fibular nail. He mentioned diabetics for both. So I was wondering if he does.
We didn't really elaborate on that, but the impression I got was that the hindfoot nail is typically reserved for the diabetic neuropathic patients that have poor sensory perception, and that way they can immediately weight bear. But we didn't dive into that. That was a whole nother conversation, but he implied that in our conversation that even though the fibular nail he's using over 65, the diabetics is kind of a subset population of that, where hindfoot nail is more preferred.
Right. Thank you.
Are any of the other panelists using hindfoot nails for acute fractures in certain patient populations?
Yeah, I mean, I use them a lot, and basically that patient population, diabetic, neuropathics, or I also use it for elderly, frail that I just want to get up and walk right away. I don't use the fibular nails. I should look into that more. Tim's study is always very convincing. But like we had a 92-year-old with a bimal, and to be honest, I'd put a hindfoot nail and let her walk on it right away.
Yeah, I think similar in those diabetic trimal ankle fractures to one, minimize the amount of the soft tissue wounds and to allow earlier weight bearing. And then just a second, your comment about Dr. White. I'm at a county hospital, cost is everything here, and haven't used an intramedullary, fibular intramedullary nail previously. You know, some of the thought processes, you know, a cortical screw is significantly much cheaper. And if I'm going for intramedullary fixation, I could opt for that in some situations. But having said that, I actually, a week after talking to Dr. White, did my first fibula nail and actually in a 56-year-old, but hemoglobin A1C of 12. So that was an indication for me. Very, very convincing conversation. And after doing that, I can put the link in there as well. I was asking about some long-term follow-up for these fibula nail patients. And they have a study in JOT from, I think, 2019 or so, looking at 300 patients, over 300 patients after fibula nails, and the complication rate and the failure rate is very low. And so I can put that in the chat room too, also, if people are interested in looking at that. So the outcomes are actually pretty strong in regards to fibula nailing. So I don't know how many people have adopted it. As far as the panelists on how many people are doing fibula intramedullary nails, and anyone or over 65.
My partners keep trying to convince me, but I haven't drank the Kool-Aid yet.
I've only done it in like the people who are older or soft tissue wounds. I think for younger people, I'm still trying to get a perfect anton reduction because the ankle's a joint. And I know the literature goes back and forth, but you know, you look at the old like biologic studies, that 1 millimeter shift rule, I still kind of go by that if I want the ankle to last 40, 50, 60 years. So I've been a little hesitant on the nails for younger people.
Yeah, I'm still a plate and screws guy, and have yet to do a fibular nail.
I've done the cortical screw technique that you mentioned a lot for pilons, particularly. That works well. I don't have any experience with the fibular nail per se, but I'd be really interested if that would allow us to use less hindfoot nails in the frail elderly and not completely fuse ankle joints basically, and still get away with a really low complication risk. So I think maybe there's a great window of opportunity for a study or for a clinical use here.
Yeah, I agree. I think with my N of 1, I would say that the time was significantly less. I think it was like 12 minutes for the whole fibula nail. I still did the medial mile, but the learning curve was very easy. It's just like anything else, start point, like any other nail that we traditionally do. It just is a different train of thought. I think it's a very simple fracture pattern. So when we're thinking simple fracture pattern, AO technique, it wants an anatomic reduction and go for direct healing. So I think that kind of intramedullary fixation, indirect approach is not as intuitive for such a simple fracture pattern in our typical SER, our SER pattern fractures. But I think there's enough literature out there to support it. And I think the cost is probably the biggest factor if you're looking at the cost analysis. And he discussed the decreased OR time, and even though the implant itself costs more, if you are at a center where you're doing more hardware removal, then the overall cost may be less because they're not removing these as often. So there's some argument for that.
Okay. It might be nice to flow into from that discussion the slides and the video he provided to us, since he wasn't able to be here.
Yeah, I thought, just from the community that I'm in and people that I talk to, fibular nailing in the trauma community, or at least my network of people I talk to with trauma, is not a highly practiced technique as far as fibular nailing. So I was just asking him some tips and tricks about his technique, and he provided a nice little fluoroscopic guided kind of technique on it. If Carolyn wants to show it.
Yeah, Chris, are you able to play that video? About 1.5 minutes.
So this is an example of how, once you've developed some familiarity, an open reduction isn't required. So this really exemplifies the importance of just being certain that you've got the correct start point and then the correct trajectory for your first drill. So I've taken the start point there, just at the very tip of the fibula. And then we pass this 6mm drill into that distal fragment, and it follows parallel to the lateral cortex of the fibula there, up and to the height that's required to fit in the fatter part of the nail. And as you can see, even just starting to engage the nail, the drill there, the mortise starts to line up.
Mm-hmm.
So that fat drill is then exchanged for a T-handle, which then prepares the proximal aspect of the fibula. And then that allows the nail. Now there's a couple of steps there. The first step was to put in the distal locking screw. And then, I'm sorry I didn't have the picture there, but you then reduce or backslap that quite commonly in order to get the anatomical length. And you can, of course, then rotate that distal fragment exactly into the correct rotation, because the lateral malleolus is attached to the nail, which is attached to the jig, which is attached to your hand. So you can position that exactly wherever you want to. And then that is completed with a proximal locking screw, which you can see there, which then stops the talus from escaping laterally.
Yeah, and you were able to avoid all the blisters too, so that's great.
Yeah, I was pleased with that particular piece of good luck.
Okay. And then also from the Q&A, someone mentioned that they use rush rods occasionally as well with diabetic patients at pretty low cost. So something to keep in mind. Dr. Erdman, I think you had a question as well.
Yeah, there was a question. It was actually on my list of questions from Dr. Holler that we didn't get to, but the use of void fillers, your void filler of choice, and pros and cons, and what your thoughts are on that.
Yeah, I think that's a great question. I think typically for these impaction injuries, they're pretty small. And so usually I'll use crushed cancellous graft to backfill the impaction. I will use a calcium phosphate if it's a large void that's left by the impaction, or if there's particularly bad bone. I think one issue that you can run into with calcium phosphate is just the liquid kind of runs into your fracture along the medial mound, can make it difficult to reduce that. So I think if you're going to choose calcium phosphate, just be mindful of that and make sure you let it completely set up and remove any excess calcium phosphate before you try to reduce the medial mound. But for me in general, it's cancellous crushed allograft.
I'd be interested, Justin, are you doing anything for the talar dome? Like if it's, like a little microfracture, or there's some off the shelf stuff you can put in there, or you kind of just letting it be when you see it now?
Well, since we kind of look back through these and publish this, haven't really seen any talar dome impaction, but like you said, I think it's something for future investigation as to whether we should try to be doing microfracture in these or trying to do something off the shelf, some kind of allograft, because 30% is pretty high. It's probably there more often than we realize, and we just haven't been looking for it. And I think we've also started to look at that for pilon fractures. I think it's honestly more common in pilon fractures than what we think it is. So I think there's certainly an area of investigation here that hopefully somebody here will look into, but we're certainly interested in it. But I don't currently do it. What about you, Augie?
Yeah, I do. If it's contained, I'll drill some stuff with a K-wire, and then I've started using an off-the-shelf, also layering that you can do is kind of minced cartilage you can pack in there. I obviously don't have any data because I've just done it a few times, but it seems like, I don't know, it makes sense to address it at the time. You kind of know it's not going to just heal itself.
Yeah, it's probably also the best, easiest to access, right? Because you just move the medial mal out of the way, and it's right there. And
Yeah.
so I think it makes sense.
I have a question for Justin and also all the panelists on regarding those talar dome impaction. We know it's there, like you said, about a third of patients have it. How long are you guys following these patients post-op? You know, they have radiographic union, their range of motion is full, their weight bearing. Is anyone having patients follow up for annual x-rays, or you just counsel them? Because we know it's there, some are worse than others. And what's your indication for following people further out, or do you not at all? I'm just curious what other people are doing.
Yeah, for all articular injuries, I'll follow people for a year and continue to follow them if they're still having issues, but usually try to follow them for a year, and whether they come back or not, it's a little bit up to them. But for this study, we had everybody that was included in the outcomes portion was at least a year. And I forget what the range was, but usually we try to follow them longer term, just so we can have a better idea of what happens to their joint, especially with these impaction injuries.
I had a question for Dr. Sanders. The concept of cost effectiveness has come up a couple times during this session, especially with regards to operative versus non-operative. I know you've been involved in a study on the topic. Can you give us your thoughts on the cost effectiveness as it relates to operative or non-operative management of fibular fractures?
I can try. I don't know how good it'll be. Honestly, the big unanswered question for us is exactly what I think you guys were just alluding to, which is how many of these people with risk of arthritis down the road actually go in and develop problems. We did do a cost-effective analysis on the operative and non-operative side, and it actually favored the operative side, but it was really driven by whatever cost a reoperation would have in the future. And really, we had no data to base that on other than best guess. So our estimate was that, maybe 10% of people would run into problems down the road. But I have no idea what the real number is, because we just don't have that quality of literature. And that's where, just like Justin just said, longer follow-up would be great. A little more depth of knowledge about what the natural history of all of these different injuries is going to be really essential for us to make great decisions in the future.
I have a question. Oh, sorry. I have a question. When you are treating someone non-operatively, how often are you bringing them back to clinic to make sure the reduction isn't lost or something doesn't change? Because that's, one of the downsides of, I think, non-op is the monitoring.
Yeah, that's a good question. What we've typically done is bring them back at about 2 weeks after the first visit, because I think you still have a window there to do something operative if there's been a shift or some movement without really getting into a higher complication profile. And then if they're good at 2 weeks, then I leave them until that 6-week follow-up check and then do a recheck then. Hopefully going to see some healing and be able to progress their rehab at that stage. I guess ideally it'd be a little bit more often than that, but like most fracture clinics, you have to be fairly pragmatic in how often you can bring people back.
In terms of the stress exam, I've heard the argument that there's some patients that you don't want to operate on them anyway. So if you have a non-displaced Weber B, are there people you're not stressing?
Yeah, absolutely. I think the majority are not being stressed with a formal stress examination. Going more from a history of weight bearing on it, or maybe like you said, if it's a patient profile that you really definitely don't want to operate on, then I'm not going to do a test that's going to lead me to a higher risk of thinking I might need an operation. So for sure, those ones I just treat very conservatively in general.
I know in residency, when this study came out, we kind of moved away from doing stress exams almost essentially altogether. What are your thoughts on that for, say, younger patients, good surgical candidates?
Well, I'd be interested to know what other guys do or other people do in terms of their treatment paradigm for these. I actually think that if someone's really a young, healthy, athletic person and needs perfection in terms of their outcome, or where you think that perfection is actually going to improve their long-term result, then a stress test or a weight-bearing view or a gravity stress test or some other test is actually pretty helpful still in helping us make sure that we're going to get ultimately a great result. But I think you do know that we can all operate on these and almost guarantee that they're going to turn out just about perfect in the vast majority of people, other than the risk of some hardware complications.
Okay.
Dr.
Well,
Sanders, can I ask a question? Sorry. So if you don't stress them with the Weber bees, do you let them weight bear right away and then see them at 2 weeks and essentially then if it's shifted or not, or do you protect them, or what are you doing?
If I got someone that I like MK was mentioning earlier, if I'm worried about somebody having to operate on them, then I'm going to treat them very conservatively, non-weight bearing in a cast. If it's somebody that I think is sort of borderline, I'm able to bring them back in 2 weeks, then I'll lean more towards protective weight bearing in an air boot and bring them back at the 2 week mark and see them then. And one of the things that at the stress test is for a lot of these ones, they they spring right back after you do the stress exam. You externally rotate them and they go right back into anatomical alignment. So there's something that's intact there that's leading them more towards staying reduced as opposed to staying displaced.
All right, so we're getting close to 9:15 Eastern time, so I'll be respectful of everyone's time and we'll wrap things up. I'm just gonna share my screen here. So just to remind everyone, next journal club sessions are in February on tibial shafts, and then March 14th, elder femoral neck fractures, and then our patellar fractures in April. And for anyone who wants to watch this recording again, it will be available through Zoom 48 hours after the session, and you'll find it on the YouTube channel for AO Trauma North America. So with that said, I want to thank everyone for participating. I want to thank my co-moderators and all of the authors for coming tonight. Really appreciate it. I thought it was a great session.